So it seems to me that we are moving from clarifying diagnosis to really putting a lot of weight for these additional mutational abnormalities in terms of prognosis. And Rami, you have shown a couple of new prognostic scoring systems that incorporate molecular factors and even dissect the patients with myelofibrosis in different groups, from those that are secondary to ET or PV2 myelofibrosis or primary. Now, how do we choose among all these? And you showed only a couple, and there are many more. And why not talk also about the risk of transformation to acute myeloid leukemia as a valid point for prognostication? So how do we go with this, choosing the best and extending to utilizing them perhaps to see who is going to transform to AML?
No, I think that's a good point. And obviously, there is a lot of overlap between those risk models. Obviously, there are common variables that we can use in those models. And some of them are depending on a clinical phenotype. Some of them are depending more on molecular phenotype. And to keep in mind also that probably the clinical phenotype sometimes reflects the molecular phenotype as well. Having said that, I think in practice, we usually start with something like the DIPS or DIPS Plus because it's a little bit more comprehensive. And we do complement it with one of the genetically based models, like the MIP70. Actually, Dr. Kirkendall published some of our work looking at when we had a discrepancy between two stages different, between somebody that, in a clinical just based model had, let's say, an intermediate, a low risk, while with a genetically inspired model was an intermediate 2, that it seems that the genetically inspired models refine the prognostic value. So especially in younger patients, I tend to, after doing the clinical model, I tend to use the MIP70 plus, for example, and deciding particularly if those patients have enough risk features of the disease to consider allogeneic stem cell transplant. And your point is well taken. I think we have to start looking more also about the risk of AML transformation. There are obviously certain predictors that are clinical as well as molecular that can help us to predict the risk of transformation in AML. And maybe as Andrew was alluding, that could be a population down the road that we would be considering allogeneic stem cell transplant earlier or intervention. For example, the group that have IDH1, IDH2 mutation are known to be higher risk for transformation. And maybe those are the patients that we should be considering some treatments earlier.